what it looks like, and how to determine where the prostate you are. So I'm very proud of my opening slide here, from walnut to coconut. The prostate is about walnut sized in a young person, but as men grow older, invariably it will grow in size, and on a large percentage of the population, it grows dramatically in size. So coconut, hopefully a smaller coconut, but and I'm proud of slide number 2 as well. Okay. Let's see. We're going to do this. I swear to God, every time I get on this computer, the controls are different. Okay, so I've told you this, I'm pretty sure I've told you this before. I've actually only assisted in prostate ultrasounds when I was a student many years ago. But I've done plenty of transabdominal ultrasounds where you could see the prostate. The problem with that, though, is that, like I said before, cancers and some other etiologies of the prostate are very subtle, very small. You're not going to see it through a full urinary bladder. So in a way, okay, now it's working. Looking at the prostate is similar to a transabdominal study of a female looking at the uterus. And also, similar to a female, if you want to see it well, you're going in. So transrectal ultrasound, truss of prostate, has improved markedly over the last couple of years. Contrast in the elastography for prostate tumor assessment is being investigated. Well, I would say, I don't know about contrast agents. I think those are being investigated, but elastography, absolutely. They're definitely using it in prostate tumors. Because once again, difficult to see, and you might suspect it or barely see it, and geez, is that a tumor? Is that just benign prostate hypertrophy? And through elastography, they're able to get a better idea. And sonography requires a thorough understanding of anatomy. So organogenesis, I just touch on it. 11th gestational week, prostate begins to form from the urogenital sinus. It's the same urogenital sinus that creates everything else down there. Prostate begins as multiple solid outgrowths forming on the posterior side of the urogenital sinus. As development continues, these penetrate surrounding the mesenchyme to form 5 lobes. So those are what we need to kind of understand, the 5 lobes of the prostate. Maturation of the gland, in other words, the growing up, maturation of the gland continues while testosterone levels are high. And that's kind of a rush of testosterone in utero. So testosterone levels decrease in the gland, and so after the baby is born, testosterone goes back down and gland enters a quiescent state. Quiescent is just kind of sleepy state until puberty, when testosterone levels rise again, and the prostate will enlarge to a normal size, to young adult size. It weighs 20 grams and measures 4 by 3 by 2. Yeah, I guess. This is the number, though, to really remember, is 25 milliliters. Because we don't weigh the prostate. So the weight here really doesn't mean anything to ultrasound techs, but we can do a volume. Now remember, 25 milliliters is the exact same thing as saying 25 cc's, because a cc is a cubic centimeter, which is basically the same thing as 25 milliliters. Prostate is composed of both glandular and fibromuscular tissue and surrounds the urethra right at the bladder, so proximal. Cephalic portion is referred to as the base, and the caudal is the apex. So an upside down triangle, somewhat shaped. So the base is the cephalic portion that's higher up. It is separate from the bladder, but it is not separate from the bladder. It is a different tissue, but it is connected to the bladder. So it is not going to be moving away from the bladder at all. The base is continuous with the bladder neck. Apex is adherent to the urogenital diaphragm. So here is our external sphincter, and the urogenital diaphragm is really the same thing here as the muscles going across here. What you see down here, that is the base of the penis. Not the greatest picture in the world, but I did like it for its pretty much its simplicity. 3 luminal structures, in other words, structures with a lumen, in other words, ducts in this case. So we have the right and left ejaculatory ducts. On this picture, you're only seeing one because it's a 2-dimensional picture. You can't get them both in there, but you're seeing one. By the way, it starts as the ductus deferens and the seminal vesicle. They come down right along here. They're running side by side, and then they meet. And when these two meet, then it becomes the ejaculatory duct, which comes down into the urethra at this structure here we'll talk about in a second. The ejaculatory duct travels within the central zone. So that's one of our lobes, really our central zone, to midline where it joins the urethra at the verumontanum. So once again, we only have one, but there's really 2 of these coming in. We're only showing one. And we're only seeing seminal vesicle up here, but what's really happening is the vas deferens from the testicles, remember. Vas deferens are coming in right at this point as well. Vas deferens comes in, meets the seminal vesicle, becomes the ejaculatory duct, traveling through the central zone. Aptly named because it is in more or less the central. The longitudinal ridge on posterior wall. Oh, I'm sorry. Let's back up a little bit. With central zone to midline where it joins urethra at the verumontanum, which is a longitudinal ridge on the posterior wall of the prostatic urethra. So really this whole thing is the veru, and then we come up here. Yeah, I double checked. The whole thing is the verumontanum, and then we do have a couple of structures right here as well. Verumontanum is located at the midpoint of the prostatic urethra near the apex and is laterally flanked by openings of the ejaculatory duct. So it's not really shown up here, but this is the location. I can never pronounce this, utricle. This is, well, you know what, I think we talk about this in just a second, but that is basically this little divot right here. And it doesn't have too much of a use, but it is always there, so it is named. Openings of the ejaculatory ducts here are not well seen, but they're on either side. And the verumontanum is really the whole thing. The whole ridge is a verumontanum, but its apex is right there. So the utricle, which we just mentioned, is a glandular grouping at the crest of the verumontanum. So let's just go back right here. Glandular grouping right there at the crest of the montagna. It is a vestigial, that's awkwardly stated here. It is a vestigial part of the paramesonephric duct in urogenital sinus. So what that means is paramesonephric duct in urogenital sinus. That's the Mullerian ducts. So that's what really is supposed to make female parts. But of course, everyone has vestigial parts of the opposite sex left over in them. So it is a homologue to the female uterus. So that little tiny grouping of cells is basically almost like a tiny uterus. Had, for instance, my hormones, even though I'm XY, if my hormone was incorrect, I didn't get the testosterone rush, I had more estrogens in utero for whatever reason, then I could have actually turned out to be someone who had all the general appearances of a female, but maybe even somewhat of a uterus, and it would actually be created from this structure right here. Kind of a weird thing to say, but that's true. The structure accounts for, it's called the Eiffel Tower sign, or the Eiffel Tower appearance, on a transverse image of the prostate gland obtained at this level. So this is more or less halfway through the prostate gland. This is a transrectal ultrasound. By the way, yes, they flip the screen on transrectals. And I think they do that because otherwise everything is just upside down. And by doing it this way, this really truly is anterior and this truly is posterior. If we did not flip the screen, then anterior and posterior would be upside down. People would just have to think about it that way. And they figured with this exam, let's just go ahead and turn it upside down. I do see in some foreign countries, people will do vaginal exams upside down as well. But that's certainly not around here. A varimontanum, just a picture here, a coronal sonogram of the normal prostate. So prostate along here in the varimontanum area. Sometimes you could see like a little triangle, and that'd be the varimontanum. And it causes, it causes a bit of shadowing and everything around it. So that creates that, they call this the Eiffel Tower. Doesn't really look like an Eiffel Tower to me, but this isn't a great picture because it's talking about the coronal section illustrates the ejector ducts and urethra joining at the varimontanum, and you don't really see it all that well. So I'm not sure why they had to use this picture in particular. But what we are seeing, actually, let's go ahead. Seminal vesicles. Here, we'll talk more about those in a second. Here is, I'm following here. That's the ureter coming in. Oh, that's right. You gotta think about the perspective. We are looking on the posterior surface of the bladder here. So on the posterior surface here, seminal vesicles, and then this is vas deferens, the ductus deferens. And they're coming in, it comes in right there. Seminal vesicle comes in right there. This is a cutaway view of the same thing. And so I guess it's an okay picture. Interesting. So back to zones. Urethra, the primary anatomic reference point dividing the prostate gland into the anterior fibromuscular stroma. So that's really, this is the only part that's not glandular. And the posterior glandular. So all of this is posterior, and really there's a central zone which they consider the transitional, the central zone and transitional zone. Glandular tissue is 2/3 of the prostate, fibromuscular 1/3 of the prostate. 3 of the zones have similar embryologic origins, all from the urogenital sinus. The peripheral zone, oh, let's see, the peripheral zone is, what color is this? Like a salmon pink, orangey thing. I don't know what color that is. This larger section here is the peripheral zone. The transition zone right here, and that is a bilobed zone. That's good to know. And the periurethral zone, is it not? Yeah, well, it's going to be periurethral is just very close to the urethra, obviously. 4th zone is derived embryologically from the mesonephric ducts, and that is the central zone. So this light purple section right here is mesonephric, and that has a very different incidence of cancer. Far more cancer along here than we have in the central zone. Well, once again, same picture. Let's just start over on the side here, the seminal vesicles here. They're going to drain in this direction. The ductus deferens coming in on both sides. When they connect, there's now the ejaculatory duct here comes together at the verumontanum, which is right about here. Urethra is coming through. Peripheral zone is posterior. Well, that's also where the transducer is. So the transducer is going to be right here. The peripheral zone is going to be the first thing you see on the transducer, the first tissue that is hit by the sound wave. And depending on how far you're looking up or down, whether it determines whether or not you see a central zone and the transition zone. So on this picture, peripheral zone, let's see if I kind of trace around the outside. It just goes like that. So all of this is the peripheral zone located along posterior, lateral, and apical portions of the gland. Its ducts drain into distal segments of the urethra between the verumontanum and apex. This right here, this would be the urethra. TZ would be transitional zone. It gets a little. This gets it's a very confusing picture here because at some point you don't see so much transitional zone, you see central zone. It really depends on where exactly you are in here. The acini and this is just like well, any other glandular organ. Breast organs have acines. What can I think? Pancreas have acini. The acini of the peripheral zone are small, round, and simple. Peripheral zone is most common location for carcinoma and prostatitis. Oh, yeah. It's Friday. Carcinoma and prostate. Approximately 70% of prostate cancers arise from this area. So, you find a little tumor here or anywhere along here is where most of your tumors are going to start. Now, here's another. This is we call this transitional zone here, but then central zone here. So we're at a slightly different location, and that is going to take time and practice to really understand the difference there sonographically. Central zone accounts for about 25% of glandular tissue of prostate and is located at the base. embedded in funnel-shaped peripheral zone. So it's kind of wrapped like a burrito. Stroma of the central zone is composed of long, tightly arranged muscle fibers that sweep around the acini. Only about 5% of prostate carcinomas arise in the central zone. So you don't find this a lot, but you notice, all this smooth muscle tissue, and that is there to express seminal fluid out of. Sorry, seminal fluid comes from the prostatic fluid out of the prostate. Sonographically, echogenicity of central zone is normally greater than that of the peripheral zone. But in this case, I would say the peripheral zone has a higher echogenicity than the central zone. So they lied. Once again, just really the same picture again. Transitional zone accounts for 5% of the prostate gland in a young man. And it's important to note, the young man. It consists of two small lobules found lateral to the proximal urethral segment. And then this happens. So once again, transitional zone as site of involvement by benign prostatic hyperplasia, or BPH. The transition zone may account for a much greater percentage of the glandular tissue as men age. And so this is a pretty remarkable change from being 5% of the gland to 75% of the gland, and just guessing there. Transitional zone is a common location for benign prostatic hypertrophy, and sonographically, it becomes more hyperechoic and visible. 20% of carcinomas occur in this area. Whoop. Then there's periurethral glandular tissue composes less than 1% of all glandular tissue. And basically, it just follows a smooth muscle wall of the urethra. Then the anterior fibromuscular stroma is a non-glandular region, which is composed mainly of smooth muscle. Surrounding structures. So the seminal vesicles are paired saccular structures, and they lie obliquely and caudally to the prostate. Obliquely and caudally. How would they be caudal to the prostate? Reservoirs for seminal fluid that fluctuate. There are reservoirs for seminal fluid that fluctuate in size and shape, secondary to levels of sexual activity. When void of seminal fluid, seminal vesicles appear as curvilinear hypoechoic structures that flare out laterally. When seminal vesicles are filled with fluid, they appear large ovoid-shaped cystic structures, often containing low-level echoes with anechoic fluid. The ampulla of the vasa deferentia are located adjacent and medially to the seminal vesicles. So the vasa deferentia, the vas deferens, they're coming along here, and then as they open up, it's considered, or as they get larger here, this is considered the ampulla. So the ampulla of the vasa deferentia are located adjacent and medial to the seminal vesicles. In cross-section, the vasa deferentia appear as thick-walled tube-like structures. Ejaculatory ducts are formed at the junction of the ampulla of vasa deferens and seminal vesicles. So yeah, at this junction, now from here, all the way here, it's that short little distance, that's the ejaculatory duct right there. Indications for sonographic evaluation are wide-ranging and ever-expanding. Like everything else we do in ultrasound, we're doing more and more things. Sonography is an example, is a source of controversy as a screening test because we can miss, even the best sonographer can miss prostate cancer when it's right there on the screen, because it can be very, very subtle and isoechoic and everything. So sometimes, you give someone false hope if you tell them, oh, you're cancer free, and they actually do have cancer. So transrectal ultrasound, oftentimes used with a abnormal digital rectal exam. Digital, not as in like electronic, as in like digital. Well, when a gland feels irregular, sonography is useful in identifying masses, cystic areas, or calcifications. Changes in echogenicity, asymmetry, distorted capsule, identifying non-palpable lesions. So, where the doctor is able to feel is not the whole gland. It happens to be the part of the gland that has 70% of the cancers, but not all of them. And perhaps the cancer is not big enough to feel yet. Biopsies, ultrasound is by far the best use of an ultrasound is during the biopsy, because we can place the biopsy needles in very specific points. I don't know, I honestly don't know if they still do seeding. So I know they used to, well, obviously they used to, I don't know if they still do. Prostate seeding is where they take little tiny rice-sized pieces of radioactive material and just place them inside the prostate. And especially with a more of a diffuse disease where you don't know exactly where the cancer is, by putting these little tiny pieces of radioactive material in, you're able to save the prostate. Radioactivity preferentially kills fast-growing cells over slow-growing cells, just like chemotherapy does. And so since cancer grows faster, it is more likely to be attacked by the radiation. But PSA tests. PSA is a protein that is specific to prostatic epithelium. Higher value, more likely malignancy is present. So like my doctor, number one reason why I chose him, he does not do digital exams, he just does PSAs. Actually, a lot of doctors are doing that now because they're finding that digital exam misses cancer and a PSA is probably more accurate. Although the range of numbers in the PSA is pretty wide, so it's not 100% conclusive, but it is a little more accurate. You can also do prostate sonography for hematospermia, there's blood and semen, pain upon ejaculation, dysuria, pain with urination, perineal pain. Prostatitis is one of the most common causes of symptoms. So sonographically, we may have higher, increased vascularity. It's hyperemic. Increased vascularity secondary to hyperemia. Isn't that the? Maybe I'm wrong. I always kind of thought that was the same thing. I'll have to double check on that. Gland may also be enlarged, less echogenic than usual. In other words, more hypoechoic than usual. It could be a focal or a diffuse process. And of course, we could be looking at a benign prostatic hypertrophy. You could look at calculus, there are a number of cysts that can occur. Abscesses would be bad, but you can have an abscess. Okay, and infertility. I basically dropped infertility from this lecture, but You look for any kind of congenital abnormality, agenesis or atresia of seminal vesicles. You could have uh, a seminal vesicle or ejaculatory duct obstruction or cyst, and that would be an obvious cause for infertility. Contraindication, fissures. So if you have any kind of evidence of a anal fistula or rectal fistula, in other words, a opening from the canal to outside the canal in a place where there ain't supposed to be an opening, that's more of a fissure. Any kind of obstructing lesions in the area, thrombosed hemorrhoids. I don't know why thrombosed more so than regular hemorrhoids. Or prostatitis itself is so painful, may prevent rectal probe insertion due to patient discomfort. So here's a transabdominal view. We don't see a lot. There is something going on. So probably a somewhat normal prostate here, and I don't know. This extra little lump down here is not normal. But when I look at here, I actually see almost like a infiltrating cancer. Do you guys see that? How it really seems to infiltrate into the bladder. That's ugly. That is not good right there. But normally, transabdominal, we're not going to see much, but definitely something going on with that one. Just kind of a picture to show how this is done. It could be done with men with their feet in stirrups, but more often they are on their left side. The reason they're on the left side because that's the side sonographers stand on, or you want them turned away from you, and since you're standing on that side of the bed, they turn to the left. And the knees up in the fetal position, probably sucking their thumb too. But it's just an endorectal end fire transducer is used to acquire transverse and sagittal images of prostate. Well, I don't think that's an end fire transducer. I do think that is a side fire because beam is coming out of the side. So, but you kind of get an idea of where the prostate is in relation to everything else. So scanning from base. So here's the base, and this is pretty much all peripheral zone there. And then as we come down, this arrow is pointing apparently to the verumontanum. I don't know. I mean, I barely see right underneath that circle there. I see, I guess, urethra, but I don't quite see it. But and then all the way down to the apex, and so that would be most inferior aspect is the apex. Sagittal view. You can see that the prostate, here's the bladder here, urethra comes down and continues on. There's a little bit of hypocholic. It doesn't mean there's fluid there. It's just the glandular tissue, the muscular tissue around the urethra itself. But this is a pretty much midline sagittal view. And then let's see, right prostate gland lobe. So yeah, so they went sagittal to the right. Transverse, normal seminal vesicle. So they've scanned beyond the prostate and are able to see the seminal vesicles. And this one shows seminal vesicle, and apparently the I hate when they say vas differentiated. This confuses me. The vas deferens vas deferens just before they come together and become the ejaculatory duct. And then on this one, it's showing two enlarged vas deferens. I honestly, I have a hard time really 100% understanding that picture. I've kind of skipped over the entire section on blood supply and venous outflow. Obviously, initially, the very first artery that comes in would be the internal iliac artery, which feeds pretty much all of our pelvic organs. And then beyond that, I just said, forget it. We don't need to know all that. But nice picture anyway. Hyperemic section over here. They suspected there was a tumor here, and they put Doppler on it, and sure enough, the blood flow increased in that area. On B, transverse abnormal peripheral zone vascular displayed by, yeah. So I guess a little bit too much blood flow here, but kind of cool. Here's that little veromontanum right there. There's that little mountain range. Whoop. Cysts. Now your book goes into a lot of detail on the different types of cysts, and wow, no, we're not doing that. So we're gonna cover this really fast. Let's see, 146. Several different cystic structures may occur in the prostate: seminal vesicles and vas deferens. Mullerian duct. So in other words, that would, I assume they're talking about this one, but I'm not 100%. Utricle cysts. In other words, you know, as that Mullerian duct was regressing, a little cyst was left behind. Seminal vesicle cysts. So the seminal vesicle is there. Prostatic cysts. So I guess anywhere in the prostate itself. Ejaculatory duct cyst, and that would be that one right there, and vas deferens cyst here. And I guess we have one more cyst. We'll call that the exophytic cyst. Okay. So I'll be honest with you guys. I'm really hating this, and I know you are too. Stick with me. We're 2/3 of the way there. I know it's where'd my time go? I know it's 1:47, but let's just, unless someone has a issue, let's just do this as one shot, and then we're done, and we get off early for a Friday. And I promise I am not going to do another PowerPoint again. I just hate these. Okay, but benign prostatic hyperplasia, that is something most men to some degree will get in their lifetimes. Three primary types. The first is homogeneous stromal hyperplasia. Second is glandular hyperplasia. Third is more of a combination where everything is getting bigger, and that's the most common. Transverse sonogram of a 57-year-old patient with frequency nocturia. So obviously he's peeing a lot and during the night, and is significantly enlarged. So you know, down here is, let's see, where would be, a little bit of trying to figure out which zone is most involved in that one. I really can't tell. Two images, a 22-year-old patient with normal crescent shape. I was going to say that looks normal to me, but this one, this is, let's see, sagittal, yeah, sagittal exam. And you can just see an enlargement there. Oh, ouch. Transurethral resection of prostate, or TURP, is done to relieve symptoms caused by compression of the urethra. So they basically go up there with a little knife on a string, or a knife on the end of a tube, and more like an apple core. Using a cystoscope, surgeon removes excess tissue, can create a relatively large defect. It's not. I don't know what they're relating large to, but it's it's obviously not a very large defect. It's only a urethra, for God's sakes. I guess it sonographically can be dramatic. That's why they call it large. Calcifications. You can have endogenous calculi are within the substance of the prostate. They form from prostatic fluid, and then exogenous calculi are found in the urethra and derived primarily from urine. So this one here is in the urethra. Ouch. And this one's out here in the prostate substance as well, the parenchyma. So endogenous are the true prostate stones. Yeah, obviously, if they're large, they may be felt. And since cancer is harder than normal tissue, when the doctor feels a hard stone, they're going to think it's cancer or suspect it. Just a couple pictures, I think, on prostatitis. This gland is, yeah, we got hypoechoic areas, but I'd also say the gland is a little bit on the round side there. Inflammation of prostate is demonstrated by increased number of leukocytes in fluid. Patients typically acutely ill with fever, low back pain, and perineal pain. And here's an increase in blood flow. Disease associated with large numbers of gram-negative bacteria. Digital rectal exam, prostate feels hard, swollen, and tender. So yeah, definitely swollen. I don't know how it's hard and tender at the same time. I guess it feels hard and the patient says, ouch, so that makes it tender. Chronic pelvic pain syndrome. In men, inflammation of prostate of unknown etiology has an incidence of 8 times higher than bacterial prostatitis. So in other words, chronic pelvic pain syndrome is just prostatitis, but they don't know why. Most studies suggest it is caused by organisms not detected by conventional cultures. So if you don't have the right culture, you're not going to find that organism. You can't just look through a magnifying glass and find it. Difficult to manage because they're difficult history. Another picture of acute prostatitis. Nothing acute about it. There's plenty of flow over here, and they're saying power Doppler, and I don't doubt it, but what's all the purple? Because normally when you have complete color coverage like this, it's elastography. That's really weird. I don't understand that picture. Let's move on. If I don't understand it, it's not important. Okay, so the cancer statistics are very confusing. 75% of all prostate cancers are detected by an abnormal PSA level. So that's why doctors more and more are just going with PSAs. Prostate-specific antigen. Prostate-specific antigen. That's what it stands for. I don't know that we said that. Prostate cancer, most common cancer in American men, and second most deadly male cancer. This is where it gets confusing. So more than 70% of prostate cancers are diagnosed in men over age 65. 42% risk of a 50-year-old man. During a lifetime with only a 2.9% risk of dying from the disease, yet it's the second most deadly cancer I guess for all the reasons people die, it's not that. I guess it's not that, because so many men die from heart disease and other things. African Americans have a 60% greater risk than Caucasians, and a higher 2.3 times higher mortality rate. Prostate autopsy found that 20% of men in sixth decade of life and 50% of men in eighth decade of life had evidence of prostate cancer. So in other words, you live long enough as a man, you're going to get it, or you have a very high chance of getting it. Now here, this is, and like I said, it's confusing. Deadly cancer and all this. My dad had it when he was 65, I think. His doctor told him, he says, Frank, don't worry about it. It's not going to kill you. You're going to die of something else before this gets you. So some prostate cancers are so common that it's almost a guarantee that a man will eventually get it. But they're so slow growing that it's almost a guarantee that the man's going to die of something else first. However, there are other prostate cancers that are more deadly and are far more likely to metastasize, and which is really what kills a person is metastasis. Most patients referred to trusts with either bladder outlet obstruction, which this guy is dealing with, abnormal PSA levels, abnormal digital rectal exam. Trust offers evaluation. Extracapsular extension. I didn't get into this because I think it's really hard to understand all the different locations they're talking about with extracapsular extension. It's kind of beyond this course, but they're basically just saying there's really two capsules. There's the external capsule. So like that one transabdominal bladder we looked at, where it looked like cancer was growing into the bladder, that would definitely be an extracapsular extension. But even within the different lobes, whether cancer stays in the peripheral zone or does it cross over into the central zone? If it does, that means it's kind of crossed over a capsule, because each lobe has its own little capsule around it. They're not terribly thick capsules, but they are there. 80% of cancers originate in the outer gland. Sometimes these numbers don't always match up. Two reasons: one, different sources, but also he says outer gland. That means peripheral and central zones is 80%, and then this one says peripheral zone just 70%. So when these numbers don't match up perfectly, don't worry about that. 20% of cancers originate in the inner gland, and that's periurethral and transitional zone. Surgical capsule defines plane between the inner and outer gland. And I could only assume that means because that's where they surgically resect the gland. They don't have to take the entire gland, they only take half of it. So prostate cancer, just like so many other cancers, can have a variety of appearances, although typically they're more hypoechoic. Adenocarcinoma, most commonly diagnosed prostate cancer, with vast majority arising from the peripheral zone. So once again, close to the transducer is the peripheral zone. And here's a tumor there and there. Could sometimes be isoechoic as well. 70% of prostate cancers originate in the peripheral zone. What did we just? Multiple, they can be multifocal. They can be single, they can be diffuse. Typically are either in the direct contact or close to the capsule. Most of these cancers involve the apex of the prostate because this is the location of the greatest portion of the peripheral glandular tissue. So yeah, that was another thing I don't think is in this PowerPoint. I might have skipped that. Not only are 70% of prostate cancers in the peripheral zone, of that 70%, most of them are all the way down in the apex. And so now we have a nice little peripheral zone mass down here as well. So extra, moving it from one zone to the another, tumors within the peripheral zone can easily spread to the central zone because of the weak interface separating these two zones. 1 to 5% of prostate cancers originate in the central zone, likely due to Wolffian duct origin. In other words, it's a different cell type entirely, and so it's less likely to have cancer, or that cell type just happens to be less likely to have cancer. Yeah. Transverse sonogram of prostate glands and liver of the variomontanum's right. Yeah, well, I'm having a hard time seeing exactly where it is, but you can see that's the so-called Eiffel Tower sign. Is it down here? This is the peripheral zone. Pretty thin, actually. This zone is looking a little bit larger. Again, down here, peripheral zone. Let's look at the arrow within the prostate. Oh yeah, it's hard to see. Also some calcifications over here. And this one, cancer down here, once again, this is also peripheral zone. It's right next to the transducer. It almost has to be peripheral zone. And then all these little calcifications up here as well. Calcifications in this gland do occur, but sometimes calcifications can be a little bit too much. And the amount of calcifications in that one tells me that this person's had some previous issues, maybe prostatitis or something going on. Biopsy guidance. Okay, we're almost there, guys. Sonography guided biopsies of prostate gland was first described in the 80s. Currently, endorectal approach is method of choice. I skipped that. Transperineal approach. Ouch. Both techniques are safe, accurate, and only mildly uncomfortable when certain precautions are taken to correctly perform the exam. Do we say anything about? Yeah, I think we do. Here, that's a track. That's actually not the needle itself. And this person, they are not doing a fine needle aspiration. They are using a biopsy gun. Biopsy gun, you literally pull a trigger, you hear a click, and when that click occurs, a large bore, kind of a thick needle, fires in and then comes back out. So it's like, pew, and takes a sample. And so, of course, this guy is going to not just have one sample. You have to sample all the way across the prostate. That's hard to even recognize as prostate here, but you're going to fire here, 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 and all the way across. They probably don't want to pierce the urethra. That'd be bad. What's that called? Anyway, so biopsy guidance. Periprostatic nerve block is the most common and popular method of anesthesia, as well as use of lidocaine gel. There is a risk of prostate contamination of fecal material using the endorectal approach, of course. Cleansing enema is used regardless of anything. You're pretty much always going to use that, I hope. But here is your transducer, and what we have here, the transducers have guides built into them, and that guide will hold on to a certain type of needle or gun, and so that needle that we You're able to guide it through. The doctor guides it. You hold the transducer. They hold the needle, and they guide it through to fire it off. Oh, we're done. Infertility. I basically skipped this. Sonography is most useful in male infertility. Evaluation of seminal vesicles and ampulla of vasa deferentia. Seminal vesicles and ampulla should be present, and well, present, of course, and free of abnormalities. No kidding. Absence of vas deferens and ampulla is a common cause or case of obstructive azoospermia. So you're just born without that. Absence of seminal vesicle may result in low ejaculate volume, though, although spermatozoa will still be present within ejaculate. That makes sense. It's a seminal vesicle. If you don't have a seminal vesicle, you have low ejaculate volume, although you still have spermatozoma, but absence of vas deferens and or ampulla is a common cause of azoospermia, with zero sperm. And we're going to talk about more of this when we get into female anatomy, but kidneys should be evaluated for associated abnormalities or atresia if absence of seminal vesicle or vas deferens were suspected. And I'm going to leave you with this little bit of valuable knowledge. Anytime, now we see this more in women, at the uterus, and it's not terribly uncommon either. If there is something demonstrably or wrong with the way the uterus or ovaries developed, the chances of there being an associated kidney problem are very high. And the same thing with men too. If there's something within the, so basically it's the urogenital sinus. The cells that, basically the cell area that created the male and female genitalia, the internal genitalia, not the external, but the internal genital tract, and the kidneys basically came from the same area. They grew at the same exact time. And so when something's wrong with one of them, one of those areas, you look to the other area for associated anomalies. It could have been, it could just be genetics. It could be just total idiopathic accident. It could be mom was exposed to a certain allergy medicine. I don't know, at a certain perfect time in development that affected the fetus at that very moment where both the sexual characteristics and the kidneys were developing. So anyway, I think that's it. That is it. 2:07. Okay. Man, you guys are already leaving? Who just left? Stinkers. Oh, no, no one left because we had 16 the whole time. All right. So starting Monday, guys, I have to have you guys on video. I already talked to, well, I talked to two of you technically. One of you apparently was able to turn off your camera entirely because they're afraid of the government. The other one of you is using a dinosaur computer that doesn't even have a video camera on it. But the rest of you, I can see that you have them on, you just have them simply turned off, which is fine, obviously. So Monday, starting Monday, we're all gonna have them on. And I hope you guys are not isolating yourselves from each other. I don't know if you guys are doing group chats and stuff like that. I hope you have an entire classroom group chat. And if you do, I encourage you guys to talk, to keep connected, because you know, we need to have a sense of community. And I hope you guys are at least doing it with each other and keeping each other in touch with how things are going. And I wouldn't mind hearing from you guys either. So I occasionally hear from a couple of you guys, but you know, don't be afraid to reach out to me. I think the other thing starting next week too. Oh, people get to hear that for